One, sir, we are live now. Now we can start.
Yeah, hello and warm welcome to the 64th session of Pediatric Orthopedic Advanced Learning Sessions. By this webinar series, we try to connect our colleagues with the world-renowned pediatric orthopedic surgeons. It's my privilege to introduce today's esteemed speaker, Professor Vincent Mosca. I think that he doesn't need any introduction to this audience. He is Professor Emeritus at Seattle Children's Hospital, and he's a leading authority on the subject. And his book is one of the authentic resources on pediatric foot problems. And now this book has a second edition also. And I request everyone to go through this book, buy this book and go through this book. The topic for the today's session is macrodactyly, a not so common condition. And I would like to express my gratitude to OrthoTV for its support to this academic initiative. So with this short introduction, now I request Professor Mosca to share his screen with us, and it's all yours. Over to you, sir.
Okay, is that showing?
No, not yet.
Okay. And show. And I need to.
Yes.
Got it now?
No, it's showing the zoom, so you need to select some other screen.
How about that? Is that showing now?
No.
No, you can open the PowerPoint in your laptop. I think your screen share of your laptop, so you can open the PowerPoint. I think it will open. Put the cursor. Can you open PowerPoint?
Yes. Yeah.
That's it?
That's it. Now just full screen. Yeah, perfect. Perfect.
Okay. Let me get it. Oh, we're still good there?
Yeah, everything is perfect. Now we can see the full screen.
Great. Well, it's so great to participate in another one of these polls sessions. I think this is my 6th or 7th. And this one's a little different than the others. As Dr. Ganjwala said, macrodactyly is not a common malformation. And although in my 40-year career, primarily focusing on foot problems in children, I've seen probably 3 dozen. That's not what most people experience. So when even a well-respected, experienced pediatric orthopedic surgeon, even one of those, the senior doctors on this call see one, it's going to be I remember what we're supposed to do with this, but then you find out that they're not all the same. And that's the point I'm going to make throughout this talk, is that they're not all the same. And as in much of pediatric orthopedics, but especially in macrodactyly, you have to be creative. You can't just do the same old thing again because it's not again and again. You have to be creative. So this, I'm going to just move this one thing on my screen to get it out of the way. There. So this was the foot of an otherwise normal girl. That's what it looked like. And that's what the x-ray looked like. So I'll go back and forth. That's what we see. The toe that at birth was larger than my second toe. And then the x-rays. And you can appreciate the toe is larger. The metatarsal is larger than you would expect. So it's easy to focus on the toe, but actually this is a problem with the entire ray, and the definition of ray being toe and metatarsal, so forefoot and toe. It's unusually large. From the Greek, the term macro means large, long, or great. A dactyl is a finger or a toe. So macrodactyly from the Greek is a long and large digit of either the hand or foot, and macrodactyly is seen in hands and feet, not necessarily at the same time, but one or the other. And it's not just the bones. It's so easy to focus on the bones and say, look how long that toe is, and wow, metatarsal is long too. But that's not the most important feature of macrodactyly. The most important feature is the circumference of the foot, because just as the bones are long, they're wide. All the tissues in that affected part are larger. The skin, fat, muscles, tendons, lymphatics, arteries, veins, nerves, everything is large. And what's so challenging about macrodactyly is that there's no demarcation in the soft tissues between normal and abnormal. Now, if you think to tumors, there are some tumors that, especially the malignant ones, that permeate into the normal tissue. But then there are others that are well circumscribed, that are encapsulated. So to remove one of those, you just remove the encapsulated part. You know when you're in abnormal tissue and you know when you're in normal tissue. But in macrodactyly, there is no demarcation between normal and abnormal. So if we're trying to take away the large part, we cannot easily, or perhaps ever, just remove the abnormal part, leaving only the normal part. And let me stop here for a minute just to remind everybody that macrodactyly is not a deformity. It's not a deformity. A deformity example is clubfoot or vertical talus. Deformity means that all the parts are there. All the bones are there, all the soft tissues are there. They're just not aligned properly. So think clubfoot. All the bones, nerves, arteries, muscles, tendons, everything is there. It's just everything's curved in. In a vertical talus, everything is curved out, but all the parts are there. Macrodactyly is a malformation, and there are 5 categories of malformation. One category is too large. One category is that it was made too small. There are too many. There are too few. They failed to separate. So macrodactyly is too large. It was made too large. Too small would be something like brachymetatarsia, when a fourth metatarsal is smaller than the adjacent metatarsals. It's a malformation, not a deformity. It's just too small. Too many is polydactyly. Too few is cleft foot or ectrodactyly, only 3 rays perhaps. And then failed to separate is syndactyly, and that could be either simple or complex. So once again, macrodactyly is not a deformity. It is a malformation made wrong. I always think, how do you remember malformation? M, malformation made wrong. And we, as surgeons, regardless of your level of expertise and skill, you cannot make this normal. You can make club feet normal, a deformity. You can make vertical talus normal, but you cannot make malformations normal. So this is what the definition is. How do we assess macrodactyly? What are surgical indications? What are the goals of treatment? And what are the techniques of surgical management? Because clearly macrodactyly cannot be corrected by physical therapy or medicines or prayer. That said, it might be that medications in the future could decrease the rate of growth or perhaps even shrink some of these, but I think that that's many years away. Macrodactyly is not common. We don't know how many there are, but it affects boys more than girls. Most commonly, it's the second ray, second digit and or ray, although the third and first may also be involved. And in about half the cases, it's more than just one ray that's involved. We don't know the etiology, but it's not hereditary. So that's one good news. When the parents come in, they have this child with really big toe or big foot, you can say, it's not, we'll be able to help your child and know that you didn't cause this, as nothing you did, and it's not going to be passed on when your child has children. the natural history. Natural history, as you know, means what happens if you do nothing to a condition. So, for example, the natural history of most cancers is that you die. Natural history of club foot is that if you don't treat it, it remains a club foot for the rest of one's life. The importance of natural history in macrodactyly is whether one important thing is whether the growth is proportionate or disproportionate. At birth, this is how the foot looked. Those rays were larger than the rest of the foot. Proportionate growth would mean that the toes and the foot continue to grow at the same rate. Disproportionate growth would mean that with growth, the affected toes and forefoot grow much faster than the rest of the foot. So neither is a desirable natural history, but if it's disproportionate growth, if they're going to be growing relatively faster than the normal parts of the foot, then that's going to be a real big problem unless it's managed appropriately. The only word I can continue to say in regard to treatment is you have to individualize. It's rare that if you see two of these in your clinical practice, they're going to be the same. And if you've seen 3 dozen, they're not all the same. So then you have to say, what are the goals of treatment? The goals, since it's a malformation, no matter who you are, I cannot make it normal. We want the child to have a good life. We want them to be able to wear normal shoes despite this gigantic ray or foot. We want reasonable cosmesis. We can't make the foot beautiful. Again, no matter who you are, no matter how many you've treated, we cannot make these feet beautiful. But we don't want to make them particularly ugly either. And we want to limit the number of operations. If we, during surgery, cannot remove every last abnormal cell, it's going to grow back with the cells that were left behind. So that's not a problem with the surgeon. That's a problem with the pathology. But you do not want to operate on these children every year by doing too little surgery, leaving too much behind, and knowing that within a very short period of time, the foot will be so large that you'll need to perform another operation so you can accomplish regular shoe wear and reasonable cosmesis. Here are some treatment options. Soft tissue debulking. Debulk means to make it smaller. So if you look at this foot, you would say, well, we can debulk that by making some incisions on the toe, taking out the fat, maybe resecting some skin. Well, you can imagine if you take out enough soft tissue to make that toe thinner, you're going to devascularize it. It'll die. It'll die. So as a primary procedure, debulking is not it. That no one ever debulks primarily. And since most people would focus on the length of the ray, one would say, how about if I do a shortening osteotomy of either a phalanx or metatarsal? If the soft tissues are already too large and you shorten the bone column, you just spread the fat out even further. So what was a large circumference becomes larger with shortening osteotomies. So it's not appropriate. And epiphysiodesis, to not change the immediate length of the ray, but over time to let the others catch up, doesn't address the primary problem, which, as I said, is a circumference. The primary problem is circumference. And whatever you do to the bones is not going to affect the main problem of soft tissue enlargement, and it might actually make it look worse. So just as soft tissue debulking is never a primary treatment, osteotomies and epiphysiodesis almost never. Plus, the timing for epiphysiodesis would be impossible to determine. Here's another treatment option, complete or partial toe amputation. You can see in the upper right that this was not really a ray enlargement. This was a distal enlargement of the second and third toes. And you can also see they have a second malformation. They have syndactyly, failed to separate. So this is macrodactyly associated with simple syndactyly of the second and third toes. And here, by performing proximal interphalangeal joint resection amputations, I was able to line the toes up, a nice arc between the tips of the toes. And although the child was still young probably just 2 or 3 years older at the final photo on the right, at least it accomplished a temporary solution to accomplish the goals. The incision on the top of the foot was that there was a contracture of an extensor tendon, and I lengthened it. And then if you look below, this is even a more distal, localized macrodactyly of the distal ends of toes 3, 4, and 5. And by doing amputations, intra-articular resections, I was able to accomplish a nice arc at the tips of the toes. And this child never came back to see me, but I assume that these grew again because there's a lot of abnormal fast-growing fat in the flaps, and that would need debulking or some other procedure. But at least for the time being, we achieved regular shoe wear, reasonable cosmesis. You can't put toenails on these, and limit the number of operations. Like I said, I only operated on each of these children once, but I have a feeling that somebody else did at least one more operation. The most typical pattern of macrodactyly is enlargement of the entire second ray, second toe, second metatarsal, including all the soft tissues, including nerves, arteries, veins, lymphatics. Every tissue is enlarged there. And ray resection is the mainstay treatment for that. This is the way you perform a ray resection. If you just made a dorsal incision and tried to ellipse the tissues, you relieve so much of the abnormal fast-growing tissue, it would grow back unacceptably. First of all, it wouldn't look good when you were done, and it would start growing back in the recovery room even before the child got home. So you have to go big, and that looks like this. You need to be as careful as you can to consider where the plantar posterior tibial neurovascular bundles are so that you maintain, preserve vascularity to the medial column and lateral column. And this is how it looks immediately post-op. This was before we put the cast on. It looks like a good-looking foot. Removed everything, every tissue that was in that ray, brought it together, and you look at the foot and say, well, it's a good-looking foot. It's got a scar, but wait, there are only 4 toes. Right, but at least it accomplishes the goals that we're looking for. And you can see in F in the lower left that we leave the base of the second metatarsal, the keystone. The goal is to just make the first and third metatarsals parallel, but don't bring them completely together to make a diamond-shaped foot. And with all the soft tissues, typically you can only get to parallel first and third metatarsals, and you leave the base just to not overcomplicate the surgery. It's not important to remove the base. Age 2 years. You can see the well-healed cosmetic scar. Foot looks good until you start counting. And here, age 7, 6 years later, I was even surprised to see that I couldn't see any evidence that the residual soft tissues had continued to grow back. So I felt happy, the child family were happy, and no one's counting toes. This was a foot that was wear a regular shoe, had good cosmesis, and 1 operation, at least so far at age 7. So another enlarged second ray, but it's not exactly the same as the last case. You can see that in addition to syndactyly to the third, the tip of the third toe is too large. So here I performed a ray resection, standard for second ray enlargement, and also performed a DIP, disarticulation, of the third toe. You can see left behind the base of the second metatarsal, parallel first and third metatarsals. And then at 13 years, she came back. She was able to play sports. She was able to dance. She could wear regular shoes. Her great toe is large. And particularly, there was a lot of extra fat and soft tissue on the lateral side of the great toe. And the thing that bothered her most was that the fat in the plantar forefoot was enlarging. So her foot looked like the bottom of a boat where it came down, instead of to a flat surface, came down to a keel. And so when she stood up, she tipped from side to side on the ship's keel. That's why a boat doesn't do well on land. It does well in the water. So this is where debulking comes in, not as a primary procedure, but I was able to elliptically take out a lot of the excessive fat, enlarged muscles on the bottom of the foot, preserving the neurovascular bundles. And I also ellipsed the skin on the lateral aspect of the great toe. She went back to sports and play. So 2 operations. And I would say that at age 13, as a girl, it's unlikely that she needed more than that second operation. Regular shoes, reasonable cosmesis, not beautiful perhaps, but acceptable, and 2 operations. Look at that foot. That's a baby. That's a baby with a great toe, a little toe, which you'll see in the subsequent pictures, and the entire forefoot way, way, way larger than my forefoot. And I'm 6'1". This is a gigantic foot. And I've seen 4 children with with the same pattern, slightly different number of toes remaining, but the same pattern. When you look at it from different angles, A is what I just showed. Look at the top of the foot. The toes, I don't know where the toes are. And look at the bottom. From the midfoot distally, it's just enlarged tissue. So I don't know whether to call this 3 central ray macrodactyly or forefoot gigantism, but it's localized to the forefoot and some or all of the toes. And like I said, I've seen 4 kids like this. And in E, you can see the comparison between the 2 feet. That right foot, I think volumetrically, is at least 3 to maybe 3.5 times as large as the left. Every now and then I see a foot like this in the plastic surgery literature, where they describe doing all these procedures of this, that, and the other thing. The chance of making that foot small enough to fit in a shoe risks killing the whole forefoot. There's no way of knowing exactly where the neurovascular bundles are. And if you start whittling and whittling that very, very large foot, it'll most likely end in disaster for the foot, that you have nothing left. Yet some plastic surgeons think that that's the right thing to do. And I've had orthopedic surgeons make recommendations, send me the case and ask, this is what they recommended. And I said, whoa, slow down. You're not going to be able to construct this foot. It's not a reconstruction because it was never normal in the first place. So it's not going to be able, you're not going to be able with surgery to construct this foot the way you want it. But we know that in a Shyam amputation, one makes the dorsal incision through the anterior ankle. There's no abnormal enlarged tissue there. And in the 4 cases I've seen, the enlarged tissue always starts about 1/2 to 1 centimeter distal to the normal position of the plantar incision for Shyam amputation. Wow, so this would be like a malignant tumor getting out of the compartment, where you know you're not going to leave anything behind because you're operating through normal tissue. And in this case, when you look at the bottom of the foot, look at C. Look at the bottom of the foot in image C. You can see it clearly ends there, midfoot. So if you just make that plantar incision 1 centimeter, 1/2 centimeter posterior proximal to the last fat you can see, it's gone. And a year later, you can have a Shyam stump that looks exactly like the Shyam stump that you would see in any other child who had a Shyam amputation for fibular hemimelia, tibial hemimelia, whatever other condition there might be. The only thing you have to remember when you're performing a Shyam amputation in this extreme, so this is a rare presentation of a rare condition, but they're out there. I've seen them. I've been consulted on these cases from others. Here you have a great outcome with the Shyam, but the tibia and fibula are either equal in length to the other side, potentially even longer than the other side. So if you perform a Shyam amputation for fibula hemimelia, the tibia is short, you can immediately put on a prosthesis. In these cases, you need to also, concurrently with the Shyam amputation, perform epiphysiodesis of the distal tibia and fibula. Because 6 weeks later, when the child is fit for the first prosthesis, even without fancy mechanics in the ankle of the Shyam prosthesis, the limb is going to be too long for the time being. So the child will get a Shyam prosthesis on this side and a shoe lift on the normal side. And then as the normal tibia and fibula on the opposite side outgrow the tibia and fibula on this side, then you can remove the lift from the normal shoe and you can start making prostheses that are more cosmetic and more functional with better mechanical devices in the ankle joints of the prosthesis. In some cases, you might actually have to go back a few years later and perform proximal tibia and fibula epiphysiodesis to shorten the limb adequately for the most cosmetic and the most functional prostheses. So this is going to be my final slide. It's a topic that I was pleased to be asked to talk about. Unusual condition, but not unheard of, and one that if you can approach it through the principles of management, in fact, that's the only way to approach it, is through principles of management and not through, I saw one case in the literature or I treated one of these. You have to be creative. You have to individualize treatment, remembering the goals, ability to comfortably wear shoes of similar size. And for the Shyam amputation, the shoe size is the same. It's just there's what the shoe on the normal foot and the same shoe size on the prosthetic foot. So you achieve number one, similar size shoes, reasonable cosmesis. I think a Shyam amputation is an attractive limb, much more attractive than a multiply operated, multiply scarred, ugly foot that was preserved. So even with a Shyam amputation, you get reasonable cosmesis, both of the residual limb and of the prosthetic limb, which is attractive, and you've limited the number of operations. Remember, in most cases, you're not going to be performing Shyam amputations. In most cases, you're going to be performing ray resections, digit shortening, and debulking procedures. And the challenge is the circumference of the foot. That's the number one consideration. Yes, it's longer, but it's wider. And no matter how much you focus on the length, what's going to be the child's biggest problem throughout their life, unless it's addressed, is the circumference. And I gave some examples of ways to manage that. So go big or go home. Don't sneak up on these. Don't do a little bit of surgery. Do the biggest surgery that you can. Get as much of the abnormal tissue out as you possibly can, while still being able to close the incisions, and know that you might need to return for a second, hopefully not a third procedure. Thank you.
Yeah, thank you, Professor Mosca, for a beautiful explanation of this. The biggest challenge for those who are practicing in India is that our patients, they are not really keen, or they don't really accept amputation as a suggestion. And what happens, like if I suggest amputation, they would go to the second or a third orthopedic surgeon. So usually for us, we have to try to find out some other surgical treatment. As you shown in the first case, like the ray resection, when it works, it's good, but it's not always possible in all the cases. Some of the cases which you showed, they are really not applicable or amenable to ray resection. So what we are going to do is like we are going to have Professor Hitesh some cases, and then we would like to discuss on that, and that would be really help us to understand the concept. So there is a problem of length, there is a problem of width, and there is a problem of the foot circumference. So how we deal with them, that we are going to do. Yeah, Hitesh, over to you. Please.
Actually, I just want to make I want to make one more comment that having traveled around the world to so many developed and resource challenged countries, I've come to appreciate over decades that what is appropriate in one country is not necessarily appropriate or acceptable in another. I remember when I went to Palestine and talking about fibula hemimelia with a single ray foot, that the orthopedic surgeon said there's no Palestinian that would accept amputation, even for an 8-inch short limb and a 1-rayed foot. And I said, but especially the girls in your culture wear these abayas, and nobody ever sees their feet. They said it doesn't matter. They're never going to accept in our culture amputation. So I learned from that. I appreciate that. And all I can talk about is how I manage things in my culture.
That's absolutely right. Like say, Indians are also like Palestinians.
Yeah, do you like to take one question? Didn't by one question was there from
Yeah,
Akash has
fine.
asked
I
that.
will take that question from Akash, and then we can have that case discussion.
Yeah, yeah.
Yeah, for very long toes, have you ever done intercalary resection of the phalanx? And do you have any experience with the use of mTOR inhibitors? That's a rapamycin for preventing recurrence after surgery.
Okay, so the first one is intercalary. Remember, these are small feet, so you cannot perform intercalary resection because I guess you'd have to take out an entire phalanx. You can't take out a shaft, and because the bone, if you shorten the bone column, if you take out a phalanx or if you resect the diaphysis of the metatarsal, as you bring the bone ends closer to each other, you bring the soft tissues out farther. So it's actually worse in the circumference standpoint. And what you want to do is the child to wear a shoe. So it's already too big to wear a shoe. It's too long to wear a shoe, but if you shorten it, you expand it, so you make it even more impossible to put that foot into a shoe. So immediate bone shortening doesn't make any sense physiologically, biomechanically. And then, as I said, the epiphysiodesis, although it doesn't shorten right away, it again doesn't address circumference. And then the second question was about medical management.
Yes, the rapamycin for the mTOR inhibition.
Yeah, I never used that. I know in the final few years before I retired, there was some work being done on that, but I never used it clinically. I'd be interested, whoever asked the question, have you used it?
Yeah. Vikas, would you like to, have you heard it or like it's just your guesswork?
Akash, not
Akash.
Vikas.
Yeah, Akash. Yeah.
So, sir, there are recently few systematic, I have just seen it in literature, few systematic reviews coming up for these limb overgrowth syndromes and macrodactyly, which involves the mTOR pathway. So, rapamycin has been shown to be like of some effect, but it's still not convincing enough.
Okay, right.
All right, that's pretty much what was known before I retired.
Okay, then there is a question from Nisarg. What about focal macrodactyly of the hallux big toe? Re-resection here would result into an unbalanced foot. What are the options over here?
Yeah, I wish I could. I'm picturing one because I've had one. I've had a fifth ray resection, and that one was really challenging. Even with the ray resection of the fifth and the reattachment of the peroneus brevis to the fourth, it kept growing back. I think I went back 3 or 4 times. There was just so much foot, but the family just wanted to keep trying. On the hallux side, I also remember one, and I did not perform a ray resection, but it was another one that I just couldn't get a handle on. I think it was another 3 or 4 operations and still not an acceptable foot. But yes, the first ray, if possible, is important to preserve. That said, after the 3rd or 4th procedure, you might consider doing a ray resection, reattaching the tibant and the peroneus longus to the second, and converting the second into the medial weight-bearing part of the forefoot. So if there were, again, I would have to see the X-rays to speak more about that.
Yeah, Hitesh, please.
Yeah, I see. See, I have the question related, okay, whether my screen is visible, Dhiren bhai?
Yes, now.
Yes.
Yeah, that's the same question I used to ask, that I have to put a few cases for the discussion, just for the understanding. And then thank you very much for the great talk. And as you said, fortunately, the second ray and the option is also very easy. The ray amputation or the ray resection is very common. But as Nisarg asked, we need to have a very common condition like the first and second ray, or the first ray is involved. What should we do actually? What are your approach for the when it's involving first and second both?
So when I look at this photograph, I see that the limb is enlarged. This is
Yeah.
hemihypertrophy.
Yeah.
Unless it's unless the photograph is deceiving, the lower leg on the left is larger than the right. The length of the entire foot, even the lateral digits, are longer. Is this hemiatrophy?
Yes. Yes, it is hemihypertrophy. Yes.
Yeah. I'm not sorry, hemihypertrophy.
Yeah.
And then you have the two long rays. Can you show the X-rays now?
Yeah, it is there. It is there. 1 minute. Just yeah. The child has got some hallux varus also.
Yeah.
At the medial cuneiform and metatarsal is deviated. So it is the hallux varus as well as the macrodactyly.
Yeah. So go back to the photo, please.
Yes. Thank you.
Okay, so the toe, the great toe is large. It's not too pathological, but the foot large in width, large in height, large in circumference. So now go back to the X-rays.
Yeah.
So I think what I would do to preserve the first ray as a weight-bearing surface would be a second ray resection and take as much of the soft tissue on the lateral side of the first ray as possible to still bring it together. And then consider, so that's going to bring the first and third rays closer together. There'll still be a relatively straight first MTP joint, but I'm not sure that I would do anything about that. Once you get the second ray out and a lot of the soft tissue on the lateral adjacent side of the first ray, the hallux might actually turn in a little bit toward the third. If you look at the other foot, the hallux valgus angle on the normal foot is 0.
Yeah.
Yeah, so the hallux valgus angle on this side is inward a couple of degrees, but if you take some of the fat out on the lateral side, on the lateral side, that might bring it in. So I wouldn't mess too much with the first ray, except second ray resection and get as much of the fat as you can appropriately take on the lateral side.
But that
No,
will not restore the length part. The length of the first ray will still remain longer than the opposite
Yeah.
side.
And so for that, you can either accept that, which in the first stage of a procedure like this might be the safest, or you can perform, let me go back to the X-ray again. It's a lot longer. One thing you cannot do is shorten the metatarsal. Okay, so you might consider shortening one of the phalanges, but that's going to then lead to an enlargement of the soft tissues because you've tried to shorten them. And internal fixation of that is almost impossible. You cannot shorten the metatarsal to bring the whole ray back because it would enlarge the soft tissues. And even though these phalanges are long, resecting them leads to increased width. That's not acceptable. And internal fixation of them is almost impossible. Crossed wires wouldn't work. The soft tissues would distract them. So what you could do is an interphalangeal joint amputation, lose the toenail, which is not the worst thing in the world, but it would allow the foot to fit more comfortably in a shoe. So you can either just do the ray resection or ray resection and either staged or simultaneous interphalangeal joint amputation.
Yeah, Hitesh.
Yeah, actually, I have prepared only the pre-op only. So I do agree. What we did in this particular case is we did the amputation of the second ray, so that will cosmetically better. In the first ray, we did the metatarsal osteotomy in align to get it into the straight. Compare what you said for first and third at the base level. So got it at the correction. And in that correction, we little shorten, not much shorten, but so it's got it straight. So what we got it straight, it's gained the length, whatever gained the length, that much we shortened. And we passed the straight wire and associated with it debulking of soft tissue at the great toe. So maintain the width. It's not been whatever is enlarged, it's reduce it. So it's reasonable foot.
So the good news is that you went big. Again, this is a term that I'm sure we use more in the United States than elsewhere, but there's a phrase that says, go big or go home.
Yeah.
You have to go for it. You just can't sneak up on Macrodactyly. You have to go big.
And Hitesh, what type of shoe wear the footwear child is using?
Yeah, the child was using the left and right is different shoes actually. This was the two difference actually. The left side was two size larger than the right side. So after this surgery, the one size has been reduced, but still it is large. The final outcome, she's skeletally mature. This girl was presented around the 13 years, and she's now skeletally mature. It's in that foot size is remained one size bigger, but she is asymptomatic and foot is cosmetically okay. She's not complaining anything.
And Hitesh, what is her leg length discrepancy?
So leg length discrepancy, we had done the epiphysiodesis. So that's opposite femur and tibia. So that fortunately our patients are ready for the epiphysiodesis, contralateral epiphysiodesis. Like this is not contralateral, it's affected
This is
side is longer.
ipsilateral. Yeah, ipsilateral.
So that we'll move on second case. This is as this Nishag has asked, this is the macrodactyly with the ingrowing toenail because of the soft tissue enlargement. How do we address?
Yeah, you can see this one also spills over to the second toe.
Yeah. Yes.
And you can see by the wrinkling of the soft tissues under the metatarsal,
Yes.
this is a very tall instep. Do you have X-ray? Oh, actually, you know what? The toenail was growing through the soft tissue.
Yes.
Yeah, you can see that on the medial side, the toenail is growing through.
Yeah.
This is a congenital ingrown toenail. I wrote an article on congenital ingrown toenail many years ago. But anyway, so let's see the X-rays then.
But soft tissue enlargement is huge, actually. This is more of the soft tissue.
Yeah.
Sorry.
So I think that let me see my pictures in the way here. Let me move my pictures. There we go. The metatarsal, the first metatarsal is of normal length.
Yeah.
The second intermetatarsal angle is wider than normal because they're being pushed apart by the enlargement of the soft tissues between the toes. And this is one where the hallux, the circumference of the hallux is just too great. This is one where I think I would do a soft tissue resection between the first and second rays. That, again, not involving bone, just soft tissue resection and remove some of the plantar skin through the V incision. So you get the metatarsals to come closer together because you removed the soft tissue between them. You could also then take some of the fat on the adjacent lateral side of the hallux and the medial side of the second toe and do an interphalangeal joint resection.
Okay.
Dislocation. So dislocation through the IP joint of the great toe, and then do a soft tissue wedge resection between those two toes.
You are totally agree that soft tissue problem, we address the soft tissue problem. However, unfortunately, we'll end up in a recurrence because it recurred very fast. So we have to do the extensive soft tissue resection here, debulking. And he's doing reasonably okay. Then couple of times the ingrowing toenails, we have to take care of the nail also.
So what did you do with the distal end of the hallux? Did you remove the end of
Yes,
the toe?
we removed. And if you see the X-ray on that, it's the phalanges is bigger.
Yes. Yeah.
The metatarsal are in size. The proximal distal one is bigger.
Yeah.
So the first surgery we did not address it, but it went in recurrence, so that we need to address it later. So that's the second question I like to ask. This child was young. What is the earliest age we can consider for the surgery? This is in a talk for the listeners, because the parents will be very much concerned. They can come at the 6 months before the child will be walking. When should we consider these surgeries?
There's some poor but believable evidence that general anesthetics are not safe for infants up to about age at least 6 months. Again, it's not clear literature, but the anesthesiologists have been trying to show that the brain doesn't tolerate anesthetics very well in the first few months of life. So if you have a choice, heart disease, congenital heart disease, you have to break the rule. But if you're talking about polydactyly or macrodactyly or other surgical procedures, it's best to limit general anesthetics in the first several months of life. So at 6 months would be my lowest age for considering doing this. And children don't really need to wear shoes until 10 or 12 months, even in cold climates, which is not India. But if I could put the surgery off until 10 to 12 months of age, I would do that.
Okay. We also used to defer up to 1 year when the child starts walking. But what we do is that we always take the footprint of the both side and measure every visit to see the length and width, whether it is circumference is increased, the length is increased of the foot, and measure and predict whether it's going to be proportional or disproportional before we take any decision, actually.
That's perfect. It sounds so simple to either take footprints, oh my gosh, either footprints or photographs, rather than getting serial MRI scans. You could do so much by just looking. Wow.
This is the third.
Let me move my pictures again. My pictures are in the way. There we go. Oh my gosh. So it's macrodactyly and syndactyly. This child is, what, 7 years old?
Yes, this is the 7.5-year-old. Yes.
And what's he been doing since birth? Just
they were going around the people, and they said that kept presented with us at this time only.
Well, you prove another point really clearly. No two are alike.
All are different. All are different. That's.
All right. Well, let's see some X-rays now.
Yeah, I think no. This is I would have missed it, but it's a syndactyly. I'm sorry for that. I can search it with it.
So, are the metatarsals particularly long?
Yes, metatarsal are all longer. The second and third are longer. Basically, this is the question for the you. This is the just question I make it. The second and third are longer. Do we consider anytime the double amputation or not? So that's the one question was there. It says
By amputation, do you mean ray resection?
ray resection. Do you do the simultaneously to ray resection?
It's certainly theoretically possible. The
Okay.
question is, how much can you remove?
Yes, that's
And
it. Because if
and,
we remove
and
that,
then
it will
bring
become width is very small on the left side. If you see the
yeah, because once you've removed the abnormal tissue, you have to
yeah
bring things back together to close them.
yeah yes
And so that would be a careful consideration of, can that be done? It would probably require at a minimal, if you do a double ray resection, performing an osteotomy at the base of the first metatarsal to abduct it, and maybe cuneiform surgery as well. But that's a broad space to eliminate. That's all I can
yeah.
say.
Dhiren bhai wanted to say something.
Yeah,
Sorry.
just I have a question. Like, say, when we remove ray, we remove the metatarsal, but what
Yeah.
about the cuneiform? Do we remove the cuneiform? That's first thing. And the second, how do we bring them closer? So, do you use some white whale or ethibond material to bring the metatarsal together?
In the typical ray resection, I bring the metatarsal distal ends of the metatarsal together with sutures. If there's a really broad gap, then, as I expected it would be in this case, you would need to perform osteotomies. And as you say, what about the cuneiforms? Because even if you perform metatarsal osteotomies, it might not be powerful enough to bring the rays together. So the ray resection might continue into the cuneiforms, and then you can bring them together better.
This
This
case,
would have been much easier to manage actually in the first 1 to 2 years of life, because
yeah
at that age the cuneiforms are primarily cartilaginous.
yeah
So you could cut those out with a knife and then bring them together. Now it'd be a saw, osteotomes. I mean, it's a much bigger deal, and there's less mobility, even removing a wedge from the cuneiforms.
this child we did manage with one secondary amputation, and that's the amputation of the phalanges of the third ray. We preserve the third metatarsal and preserve the width, because width was not more compared to the last case. So we managed to get the width, and the second and ray, third two phalanges we did amputation.
Wow, great.
So we got it cosmetically reasonable. I had the photograph, but I thought I did not have the time. So that's I prepared the fourth case. This is child with the crippled tubular
Gigantic.
Weber, gigantism, with what you have shown the last case, similar to that.
Yeah, yeah.
Yeah,
I
but
really cannot imagine. All right, so I can't speak to the culture of the family, and culture beats everything else, right? Everything
yes.
else is just words. Um, Culture is what matters. But this child has enlargement of the buttocks, of the limb. Um, this is this is hemihypertrophy, but really exaggerated. That is a big butt.
Yeah. Yeah. That's really the big one is.
Is it is Were there any vascular malformations? Is this Klippel-Trenaunay Weber or
Yeah, Klippel Weber. This is Klippel.
okay? Yeah, yeah. So this is going to be a huge problem for the child long term. I'm sure that there's going to have to be some more proximal surgery when that enlarged proximal thigh and buttock keep growing and growing and growing. The heel looks relatively normal.
Yeah.
When I look at that, you can see the enlarged forefoot, like in my example. There's a little bit of an enlargement of the midfoot laterally. The heel looks normal. So this is a case where, in my culture, I would strongly recommend a SIME amputation distal tibia and fibula epiphysiodeces, and just explain that the child is going to need so much treatment for the more proximal tumors in the future that if we can get this eliminated and get the child going, normal development of walking, running, those things, that would be in the child's best interest. And again, I cannot conceive of a reasonable way to shrink that foot without an amputation.
Yeah, absolutely right to have it, because we have done also multiple surgery for removing the third ray and with the plantar aspect of the soft tissue and debulking with epiphysiodesis. With epiphysiodesis of the distal femur and proximal tibia, the length part is okay, but the foot is still looking grotesque. It's not looking great, but it's reasonable.
So it's so easy for me sitting back after decades of doing this work to say, I know what's best for you. And parents don't want to hear that. And no matter how absolutely convinced I am of the best answer, all I can do is educate them. I can't make their decision for them. And I acknowledge that. So especially for the younger people on the Zoom call, we as physicians are consulted not to do things except make appropriate assessments and recommendations. We are not paid to do what the parents think is best or what other consultants think is best. We are consulted and we are paid to give our educated and ethical recommendations. That's it. So if the parents come in, they say, we just want you to remove the third toe and then we're done. You can say, that's your choice. That's your decision. But I have my ethics also. And I believe that would not be in the child's best interest or your best interest. So if that's what you want to have done based on your research, based on other people or doctors you've spoken to, then you'll need to see somebody else. But you can't make me do what you want if I don't believe it's among the choices of the good things to do, the best things to do. So again, for the young people on this call, just remember that you are not supposed to do anything other than what you believe is right, ethical, and moral based on your education, training, and experience. That's all you're required to do. You can never be sued for not doing what somebody else wants you to do if it's not, in your opinion, ethically right.
Yeah.
So
It's couple of questions, Dhiren. We'll ask before you finish. Do this enlargement progress after skeletal maturity? What is your experience ever? Sherry want to ask.
Say again?
Do this enlargement progress after skeletal maturity?
Oh, no. No,
Okay.
they seem to grow according to growth hormone.
Okay. And one more question, hemihypertrophy has to be uniform or not? Because
Hypertrophy uniform in regard to what?
uniform for the tibia, femur, and the foot size along with the foot. May not be. It will be varied. It is also different presentation. As said, both all macrodactyly is different. It's again hemihypertrophy is also different.
Exactly. And that's hemihypertrophy. So even though Klippel-Trenaunay-Weber is one of the categories of hemihypertrophy, it's unique in the fact that it's got these vascular malformations. And depending on where they are in relationship to the growth plates, some growth plates are going to experience greater growth than those in which the vascular malformations are not adjacent.
Yeah, correct.
So thank you very much, Professor Mosca and Professor Hitesh. And at the end of the session, I would just like to summarize that this is one condition where still we don't have a reasonably satisfactory treatment for parents. And we really need to work more. We need to find out the reasons for this pathology. And probably in future, we will have some better solution for this condition. So with these words of optimism, I thank Professor Mosca and Professor Hitesh and everyone for joining that. Thank you.
Well, thank you for inviting me again. I love these sessions. I have such a strong connection with certainly you, dear, and Hitesh, and Thomas, and my other great friends in India. So if not before then, I'll see you all in next January.
Yeah, sure.
Sure. Thanks.
Thank you. Yeah.
Go big
Thank
or
you.
go home.
Bye.
Thanks.
Bye-bye.
I'll send them all to Seattle, Vince.
Okay.
Okay, bye.
Okay, bye.